Understanding gastroesophageal reflux in neonates requires distinguishing between normal physiologic processes and pathologic conditions requiring intervention. This fundamental distinction guides clinical decision-making and prevents overtreatment of normal developmental phenomena. Gastroesophageal reflux, GER, represents normal retrograde passage of gastric contents into the esophagus, occurring in virtually all neonates multiple times daily without requiring treatment. In contrast, gastroesophageal reflux disease, or GERD, develops when this retrograde flow causes troublesome symptoms or medical complications impacting the infant's health and development. Neonates face multiple factors predisposing them to increased reflux frequency. The lower esophageal sphincter demonstrates functional immaturity with decreased resting tone and increased transient relaxations, tearing the primary mechanism allowing gastric contents to reflux. Delayed gastric emptying, particularly in premature infants, prolongs gastric distension and increases reflux likelihood. The predominantly liquid diet creates fluid environment at the gastroesophageal junction, facilitating retrograde flow. Obligate supine positioning removes gravitational assistance that upright positioning provides in older children. The clinical manifestations of pathologic GERD encompass multiple organ systems. Gastrointestinal symptoms include regurgitation and vomiting, though key distinguishing features involve associated complications such as failure to thrive, feeding aversion, or esophageal inflammation signs. Behavioral manifestations often provide earliest clues to pathologic reflux. Infants may demonstrate irritability, back arching, or apparent discomfort during feeds, suggesting acid reflux causes esophageal inflammation. However, these behavioral signs are nonspecific and frequently occur without documented reflux episodes. Respiratory symptoms represent potentially serious complications, including apnea, chronic cough, stridor, or recurrent pneumonia from aspiration. Poor weight claim serves as an important pathologic reflux indicator, particularly when feeding difficulties result in inadequate caloric intake. The challenge lies in accurately distinguishing between physiologic GER, requiring no intervention, and pathologic GERD, demanding systematic evaluation and treatment. Most infants with simple regurgitation demonstrate normal growth without requiring medical intervention, emphasizing the importance of careful clinical assessment before initiating treatment protocols. The management of gastroesophageal reflux in neonates follows a systematic, tiered approach, prioritizing evidence-based interventions while avoiding unnecessary pharmacologic treatment. Non-pharmacologic management represents first-line treatment for all infants with suspected GERD. These interventions address underlying physiologic factors predisposing neonates to reflux episodes. Positioning strategies utilize gravity and anatomical positioning to reduce reflux frequency. Left lateral positioning after feeds demonstrates superior efficacy compared to right lateral positioning, because it positions the gastroesophageal junction above gastric contents. Prone positioning shows greatest reflux reduction, but requires continuous monitoring due to increased SIDS risk. Feed modifications address volume and composition factors contributing to reflux. Smaller, more frequent feeds reduce gastric distension, decreasing pressure gradients favoring reflux while improving gastric emptying. Post-feed upright positioning for 30 minutes utilizes gravitational assistance to promote gastric emptying. Thickened feeds require careful consideration. While thickening agents reduce visible regurgitation, they don't consistently decrease acid reflux episodes, measured by pH monitoring. Additionally, thickened feeds increase caloric density, potentially worsening reflux in premature infants by slowing gastric emptying. The FDA has issued warnings about certain commercial thickeners in preterm infants due to necrotizing enterocolitis associations. Pharmacologic management presents significant challenges. Current evidence demonstrates limited efficacy for acid-suppressive medications in treating infant GERD symptoms. No medications have FDA approval specifically for infant GERD, highlighting insufficient efficacy data. proton pump inhibitors should be reserved exclusively for documented esophagitis through endoscopic evaluation, not empiric treatment of behavioral symptoms. Metoclopramide carries unacceptable risks of extrapyramidal side effects, including irreversible tardive dyskinesia, significantly outweighing potential benefits. Surgical management through Nissen fundoplication remains reserved for severe refractory cases where GERD threatens life or causes failure to thrive despite maximal medical management. This procedure carries substantial morbidity, including gast bloat syndrome, dysphagia, and dumping syndrome. The key principle recognizes that most neonatal reflux represents a developmental phenomenon improving with maturation. Therefore, conservative management with non-pharmacologic interventions often proves sufficient while avoiding potential complications associated with pharmacologic or surgical interventions. Cholestasis represents one of the most important hepatobiliary disorders in neonatal medicine, requiring urgent recognition and systematic evaluation. Early intervention prevents irreversible liver damage and optimizes outcomes. Cholestasis occurs when bile flow becomes impaired, resulting in conjugated bilirubin accumulation in the bloodstream. This distinguishes it from common unconjugated hyperbilirubinemia seen with physiologic jaundice. The liver continues producing bile, but obstruction or hepatocellular dysfunction prevents normal flow into the duodenum. The key diagnostic criterion for certification examinations is that direct, conjugated bilirubin exceeding 2 mg per deciliter or comprising more than 20% of total bilirubin indicates pathologic cholestasis. Unlike physiologic jaundice, where unconjugated bilirubin predominates, any significant conjugated bilirubin elevation demands immediate investigation. Conjugated hyperbilirubinemia never represents a benign, self-limiting condition. Clinical presentation provides diagnostic clues. Clay-colored or acolic stools occur because bile pigments cannot reach the intestine. Dark urine develops because water-soluble conjugated bilirubin gets filtered by kidneys. Hepatomegaly frequently accompanies cholestasis from inflammation, fibrosis, or metabolic derangements. The differential diagnosis encompasses several categories. Biliary atresia represents the most common surgical cause, typically manifesting after 2 weeks as progressive inflammation destroys bile ducts. This demands urgent recognition because surgical intervention becomes less effective with age. Total parenteral nutrition-associated cholestasis develops in infants requiring prolonged parenteral nutrition. Contributing factors include lipid toxicity, lack of enteral stimulation, and infections. Metabolic and genetic disorders can present with cholestasis, including bile acid synthesis disorders and storage diseases. Infectious causes encompass torch complex and acquired sepsis. Anatomic abnormalities such as choledochal cysts create mechanical obstruction. Diagnostic evaluation follows systematic approach, beginning with comprehensive liver function tests. Ultrasound provides non-invasive biliary anatomy assessment. HIDA scanning evaluates bile production and flow, distinguishing hepatocellular dysfunction from biliary obstruction. Liver biopsy remains the gold standard for definitive diagnosis, providing histologic information about inflammation, fibrosis, and architectural changes. This systematic approach ensures appropriate diagnosis and timely intervention, preventing progression to irreversible cirrhosis. Biliary atresia represents one of the most time-sensitive diagnoses in neonatal medicine, where early versus delayed recognition determines survival. This condition requires understanding both its pathophysiology and critical timing and management. Biliary atresia occurs as a progressive inflammatory process, systematically destroying bile ducts inside and outside the liver. This active inflammatory condition continues causing damage daily, not a static congenital malformation. The inflammation obliterates bile ducts, creating complete obstruction to bile flow. Without intervention, this leads inevitably to biliary cirrhosis, liver failure, and death within 2 years. The incidence of 1 in 10,000 to 15,000 live births makes this rare enough that practitioners may never encounter a case, yet common enough that every neonatal provider must maintain vigilance. Clinical presentation provides key diagnostic clues, distinguishing biliary atresia from other neonatal jaundice causes. Jaundice persisting beyond 2 weeks should trigger immediate concern. While physiologic jaundice typically resolves by this time frame, biliary atresia causes persistent, progressive jaundice as conjugated bilirubin accumulates. Acolic stools represent the most valuable clinical sign parents can recognize. These pale, clay-colored stools occur because bile pigments cannot reach the intestine. Parents describe them as putty or chalk. Combined with dark urine from filtered conjugated bilirubin, this creates characteristic patterns, prompting urgent evaluation. Hepatomegaly develops as the liver becomes inflamed and fibrotic from ongoing inflammation and bile stasis. Diagnostic approach includes ultrasound, revealing absent or small gallbladder. HIDA-scan demonstrates complete biliary obstruction, as radiotracer accumulates in liver but cannot reach intestine. Liver biopsy provides definitive histologic diagnosis. Intraoperative cholangiotogram during surgical exploration definitively confirms absent patent bile ducts. Management centers on Kasai, portoenterostomy. Connect intestinal loop directly to liver surface where microscopic bile ducts may remain patent, bypassing obliterated extrahepatic ducts. Critical timing cannot be overstated. Success rates decline dramatically with age, with optimal results when performed before 60 days. After 90 days, success becomes extremely poor. Even with successful Kasai procedures, 70 to 80% eventually require liver transplantation despite initial surgery success. This underscores why biliary atresia represents a true neonatal emergency, requiring immediate recognition and urgent intervention. Intussusception represents one of the more challenging diagnoses in neonatal gastroenterology because it's uncommon in this age group, yet can present with life-threatening complications when it occurs. Understanding this condition requires recognizing both its rarity and its potential severity in the newborn period. The pathophysiology involves telescoping of one bowel segment into an adjacent segment, creating a mechanical obstruction that can compromise blood flow to the involved intestine. While intussusception typically affects older infants between 6 and 24 months of age, when it occurs in neonates, it often indicates an underlying anatomical abnormality, serving as a pathologic lead point. Unlike the classic presentation in older children, neonatal intussusception presents with frustratingly nonspecific symptoms that can mimic other common neonatal conditions. Feeding intolerance, vomiting, and irritability are hallmarks, but these findings occur in numerous neonatal disorders. The development of abdominal distension and tenderness provides more specific clues, but these signs may appear late in the clinical course. Blood in the stool represents a particularly important finding because it suggests compromised blood flow to the intussuscepted bowel segment. However, bleeding may initially be occult, requiring careful attention to stool appearance and testing for blood when clinical suspicion exists. The classic currant jelly stools described in older children are less common in neonates. The diagnostic challenge in neonatal intussusception centers on maintaining appropriate suspicion despite the condition's rarity. The nonspecific nature of early symptoms can lead to delays in diagnosis, during which time the risk of bowel necrosis and perforation increases significantly. This timing factor makes intussusception a true emergency when it occurs in the neonatal period. Ultrasound examination provides the most valuable diagnostic tool when intussusception is suspected. The characteristic target sign or donut sign appears when the ultrasound beam crosses the intussuscepted bowel segment, showing the telescoped layers as concentric rings. This imaging finding, when present, confirms the diagnosis and helps localize the obstruction. While contrast enema can be both diagnostic and therapeutic in older children, neonatal intussusception typically requires surgical intervention. The higher likelihood of pathologic lead points and the increased risk of perforation in small infants make surgical reduction the preferred approach. The surgical team can directly assess bowel viability and address any underlying anatomical abnormalities that may have precipitated the intussusception. The key to successful outcomes lies in maintaining clinical suspicion and recognizing that while intussusception is uncommon in neonates, its occurrence demands immediate attention and intervention to prevent serious complications. Meconium plug syndrome and small left colon syndrome represent related functional obstructions sharing common pathophysiology, but differing in anatomical locations. Understanding these conditions requires recognizing their associations with specific maternal and neonatal factors, frequently appearing on certification examinations. The pathophysiology centers on impaired colonic motility, leading to functional obstruction from impacted normal meconium. In meconium plug syndrome, obstruction occurs in the sigmoid colon, while small left colon syndrome involves obstruction at the splenic flexure with abnormally small descending colon caliber. The most important clinical association involves infants of diabetic mothers, accounting for up to 50% of small left colon syndrome cases. This connection occurs because maternal diabetes leads to fetal hyperinsulinism, causing neonatal hypoglycemia. Hypoglycemia triggers increased glucagon secretion associated with intestinal hypomotility and delayed meconium passage. Prematurity represents another significant risk factor because immature myenteric plexus development impairs normal intestinal motility. Maternal magnesium therapy for preeclampsia can cause neonatal hypermagnesemia, leading to decreased acetylcholine release and myoneural depression affecting bowel function. Clinical presentation typically involves healthy-appearing infants failing to pass meconium within 24 to 36 hours. This timeline becomes critical because normal infants should pass meconium within this window, making delayed passage a significant red flag. Generalized abdominal distension develops as proximal colon dilates with retained meconium and air. Bilious emesis may occur, but unlike mechanical obstructions, these infants maintain stable vital signs and don't appear systemically ill. Diagnostic approach centers on water contrast enema, serving as both diagnostic gold standard and primary therapeutic intervention. The study reveals dilated proximal colon with abrupt narrowing at obstruction site. The hyperosmolar contrast draws fluid into bowel lumen, softening spissated meconium and facilitating passage. Management remains conservative in most cases, with repeated enemas as needed. Surgical intervention is rarely required. Critical diagnostic consideration involves differentiating these functional obstructions from Hirschsprung disease and cystic fibrosis. If symptoms persist after initial treatment, further evaluation becomes mandatory. However, most cases resolve completely within the first month with excellent prognosis. This condition exemplifies pattern recognition importance in neonatal care, where maternal diabetes association provides crucial diagnostic clues frequently appearing in certification examinations. Total parenteral nutrition-associated liver disease represents one of the most serious iatrogenic complications threatening infants requiring prolonged nutritional support. Understanding this condition requires recognizing its multifactorial pathogenesis and critical prevention strategies, since reversal becomes extremely difficult once hepatic damage occurs. The pathophysiology involves multiple interconnected mechanisms damaging hepatocytes and impairing bile flow. Lipid peroxidation occurs when lipid emulsions, particularly soy-based formulations, generate toxic metabolites directly injuring liver cells. Absence of enteral nutrition eliminates normal bile flow stimulation and gut hormone production, leading to biliary stasis and bacterial overgrowth. This produces endotoxins that translocate across intestinal barriers, triggering systemic inflammation, further damaging hepatic function. Reoccurrent sepsis compounds injury through inflammatory mediators. Risk factors include prematurity, most important due to immature hepatic enzymes and reduced antioxidant capacity, TPN duration, significant dysfunction typically after 2 weeks, complete absence of enteral nutrition, sepsis episodes, and lipid emulsion composition. Prevention strategies target underlying mechanisms. Early trophic enteral feeds, even minimal volumes of 1 milliliter per kilogram daily, stimulate bile flow and maintain intestinal barrier function. Cycling parenteral nutrition after 2 to 3 weeks provides critical hepatic rest periods. Lipid restriction to 1 gram per kilogram daily minimizes peroxidation substrate while providing essential fatty acids. Alternative lipid emulsions, such as SMOF or omega-ven, demonstrate reduced hepatotoxicity compared to traditional soy-based formulations through better antioxidant profiles. Ursodeoxycholic acid at 10 to 15 milligrams per kilogram daily helps maintain bile flow through choloretic and anti-inflammatory actions. Monitoring requires systematic, proactive approaches. Weekly liver function tests allow early dysfunction detection. Direct bilirubin serves as the most sensitive early cholestasis indicator. Ultrasound detects biliary sludging and structural changes. The fundamental principle recognizes that prevention strategies implemented early prove far more effective than attempting to reverse established dysfunction. Once significant damage occurs, changes may be irreversible, potentially necessitating liver transplantation. This reality underscores why every infant receiving parenteral nutrition requires vigilant monitoring and aggressive preventive measures. From TPN therapy initiation. Understanding how gastrointestinal concepts are tested becomes crucial for certification success. Certain high-yield topics appear consistently, and mastering these core concepts significantly improves performance. Emergency recognition represents the highest yield category. When you see bilious emesis in clinical vignettes, consider malrotation with volvulus until proven otherwise. This life-saving clinical pearl appears consistently on exams. Similarly, pneumatosis intestinalis on radiographic images immediately signals necrotizing enterocolitis at Bell stage 2 or higher, regardless of other findings. Failure to pass meconium beyond 48 hours should trigger consideration of Hirschsprung disease or mechanical obstruction. Exam questions often present this with distracting information, but this timeline remains the critical diagnostic threshold. Critical differentiation points require distinguishing conditions with different management approaches. Gastroschisis versus omphalocele distinction hinges on protective sac presence. Gastroschisis has no covering membrane, while omphalocele is covered by translucent sac. This difference determines initial management, surgical timing, and prognosis. Understanding why necrotizing enterocolitis differs from spontaneous intestinal perforation requires recognizing different presentations and timelines. Spontaneous perforation typically occurs earlier, without preceding feeding intolerance and systemic illness characterizing NEC. Esophageal atresia variants present distinct management challenges. Type C, most common with distal fistula, allows gastrointestinal air entry, producing different radiographic findings compared to isolated atresia showing gasless abdomen. Management principles form most clinical questions' foundation. Bell's staging system provides systematic framework guiding treatment decisions. Questions frequently present scenarios at different stages, requiring appropriate stage identification and corresponding management. Preoperative stabilization requires condition-specific modifications. Duodenal atresia requires hypochloremic alkalosis correction, while malrotation demands immediate surgical intervention. Post-operative complications represent high-yield areas, where understanding natural history helps predict complications. Anastomotic strictures develop in 1/3 of infants following NEC surgery. Gastroesophageal reflux affects nearly all children with repaired esophageal atresia. Short bowel syndrome nutritional management integrates parenteral nutrition, enteral feeding strategies, and complication prevention like cholestasis. These concepts represent the most clinically significant conditions encountered in practice. Mastering these high-yield topics ensures confident examination approach while building essential clinical care knowledge. As we conclude our comprehensive review of neonatal gastrointestinal disorders, these fundamental principles serve as foundation for certification exam success and excellent clinical practice. The most important concept you must internalize is that every instance of bilious emesis represents a surgical emergency until proven otherwise. When encountering bilious vomiting in any scenario, whether examination or practice, immediately assume malrotation with volvulus. This mindset saves lives because the narrow intervention window demands immediate recognition and action. Understanding the two highest mortality gastrointestinal emergencies, malrotation with volvulus and necrotizing enterocolitis with perforation, requires recognizing early presentations before catastrophic complications develop. Malrotation can progress from bilious vomiting to complete bowel loss within hours, while NEC advances from feeding intolerance to perforation with similar rapidity. Early recognition dramatically alters outcomes. Abdominal wall defects demand specialized initial management, differing significantly from standard neonatal care. Exposed bowel in gastroschisis requires immediate protection and staged closure, while omphalocele management must account for frequently associated anomalies. Master classic radiographic findings appearing consistently on examinations. Double bubble sign signals duodenal atresia. Pneumatosis intestinalis confirms necrotizing enterocolitis, and corkscrew appearance suggests malrotation. These represent pathognomonic findings, eliminating diagnostic uncertainty. Universal management principles apply across scenarios. Gastric decompression prevents complications from distension or aspiration. Fluid resuscitation addresses third spacing and ongoing losses. Broad-spectrum antibiotics prevent bacterial translocation. Early surgical consultation ensures appropriate intervention timing. Long-term outcomes depend on associated anomalies, disease extent, and intervention timing, rather than specific conditions. Isolated duodenal atresia has excellent prognosis, while the same condition with complex heart disease carries greater risks. Prevention strategies offer powerful tools for reducing acquired complications. Human milk feeding provides 6 to 10-fold necrotizing enterocolitis risk reduction through immunoglobulin transfer and beneficial microbiome establishment. Standardized feeding protocols prevent rapid increases triggering NEC. These concepts form neonatal gastrointestinal care cornerstones, representing conditions most likely impacting patient outcomes. Master these fundamentals for certification success and clinical judgment essential for excellent patient care. A 5-day-old term infant presents with sudden onset of bilious emesis. The infant was previously feeding well with normal stools. The most appropriate next step in management is contrast enema, immediate surgical consult, and upper GI series, observation with serial abdominal examinations. The correct choice is immediate surgical consult and upper GI series. This question is testing your knowledge of emergency management of suspected malrotation with volvulus. Contrast enema is incorrect because it's not the diagnostic test of choice for upper GI obstruction and wastes valuable time. Observation with serial abdominal examinations is incorrect because bilious emesis in a previously well infant is a surgical emergency until proven otherwise. Delay could result in bowel ischemia and necrosis. A 10-day-old preterm infant, 28 weeks gestation, develops feeding intolerance, abdominal distension, and bloody stools. Abdominal radiograph shows pneumatosis intestinalis. Laboratory studies reveal thrombocytopenia, metabolic acidosis, and hyponatremia. The appropriate management includes broad-spectrum antibiotics, NPO status for 7 to 10 days, serial abdominal radiographs, enteral feeding with elemental formula, metronidazole, and serial clinical examinations. Immediate surgical intervention with bowel resection. The correct choice is broad-spectrum antibiotics. NPO status for 7 to 10 days, serial abdominal radiographs. This question is testing your knowledge of NEC management according to Bell's staging. Enteral feeding with elemental formula is incorrect because all enteral feeds must be stopped with proven NEC. Immediate surgical intervention is incorrect because surgery is only indicated for perforation or clinical deterioration despite medical management, neither of which is present in this case. A newborn presents with an abdominal wall defect with intestines protruding through a para-umbilical opening. The umbilical cord inserts normally into the abdomen and there's no covering membrane over the intestines. The infant is at increased risk for associated cardiac and chromosomal anomalies, intestinal atresia and prolonged ileus, renal and vertebral anomalies. The correct choice is intestinal atresia and prolonged ileus. This question is testing your ability to differentiate gastroschisis from omphalocele and identify the associated complications. Associated cardiac and chromosomal anomalies is incorrect because these are associated with omphalocele, not gastroschisis. Renal and vertebral anomalies is incorrect because these are more commonly associated with vacteral, not typically linked to gastroschisis. A 2-day-old term infant has not passed meconium since birth and has progressive abdominal distension. Rectal examination results in explosive passage of stool and temporary improvement in distension. The most specific diagnostic test for this condition is barium's enema showing transition zone, plain abdominal radiograph, rectal biopsy showing absence of ganglion cells. The correct choice is rectal biopsy showing absence of ganglion cells. This question is testing your knowledge of Hirschsprung's disease diagnostic approach. Barium enema is incorrect because although it may show a transition zone, it's not always evident in neonates and isn't the gold standard. Plain abdominal radiograph is incorrect because findings are nonspecific and cannot confirm the diagnosis. A newborn is noted to have excessive oral secretions and choking with the first feeding attempt. An oral gastric tube cannot be passed beyond 10 centimeters from the lips. Chest and abdominal radiographs show the tube coiled in the upper chest with gas in the stomach and bowel. The most likely diagnosis is esophageal atresia with distal tracheoesophageal fistula, isolated esophageal atresia, tracheoesophageal fistula without esophageal atresia. The correct choice is esophageal atresia with distal tracheoesophageal fistula. This question is testing your knowledge of EA-TEF variants and their radiographic findings. Isolated esophageal atresia is incorrect because this would show a gasless abdomen with no air in the stomach or bowel. Tracheoesophageal fistula without esophageal atresia is incorrect because this would allow passage of the orogastric tube into the stomach.